Mr. Richardson. Evan, welcome to Inside Reproductive Health.
Very happy to be here. Thanks for making time, Greg.
I've got to tell you that I'm a little bit not looking forward to when this episode comes out for a reason that I've gotten very protective of the audience of the show in the last couple years, because now we're sort of the only media outlet for the business side of fertility, which has a lot of people asking me like, hey, can I come on the show? Can I pitch this, or can we talk about this topic? And now, like, I also want to get to the point where we're in sponsorship mode. I didn't think that was the realm that you were in, but I just know that people that have asked me to come on are going to be like, what the heck? Why'd you let that guy on? You didn't let us. I do have an explanation, but I want to go back into I want to start backwards a little bit before we talk about what Form Health is, but if we could start with just why fertility, what is the relationship to fertility? Then I'll give my answer, and then we'll work back and then forward again.
Well, that makes a lot of sense. So I feel like to answer that question, I need to tell a little bit about Form, which is that we are a concierge telemedical weight loss service. So we work within the realm of medical support. We are a medical practice. We treat patients and we work with those individuals to meet their broader healthcare goals within the context of helping them to lose weight. And it turns out that weight loss can be really important for fertility for a number of reasons. For a number of practices, folks have a BMI cutoff, and patients who come in above that cutoff can't receive certain services because of risks around sedation. For other folks, there's a real demand for surrogates, but sometimes the surrogates don't meet a BMI threshold that's required. And then for the broad population, risks around becoming pregnant and then carrying a child to term all go up as BMI goes up from the sort of obesity level, which is a BMI of 30. And so we've worked with fertility practices now for quite a while to help them to bring patients into the realm of being treatable from a fertility perspective, bring their BMI down below any sort of hard ceilings they may have, to increase the number of surrogates that they have available, and then also just to improve sort of all of the outcomes related to fertility, all by helping their patients reduce their body mass index. And it turns out that the relationship between fertility and BMI is fairly clear, right? All risks to becoming pregnant or to carrying a child to term come down as a patient brings their BMI back towards the sort of clinically normal threshold below a BMI of 30. And that's really where we help. That's where we work with fertility providers to help to improve all of their outcomes and broaden the base of patients and surrogates that they can work with.
What other subspecialties of healthcare, if any, are you working with?
Yeah, well, so that's a really great question. The answer is all. So we work with primary care providers, we work with OBGYNs, we work with folks in the orthopedic space, and then kind of everybody else. I would say those are the big four, with fertility kind of leading the way for the subspecialties that we work with today. But we do have referring providers that come from the broad swath of medical subspecialties, because there really is no area of care that wherein patient outcomes are not improved by helping those individuals with a BMI over 30 to bring that BMI down below the obesity threshold.
Well, I don't really give a crap about those other subspecialties, but what I am interested is a little bit more in how you partner with clinics. But the reason why I was okay with having you on the show is because there is a tremendous bottleneck in fertility right now. There's simply more patient demand than there are providers to be able to treat them. And we need other means to help do, I don't know if triage is the right word, but to help with some of the treatment that doesn't need to be going on at a fertility specialist, so that the fertility specialist can do what only the fertility specialist can do. And so talk a little bit but I also brought you on because it didn't seem like, you were necessarily that you had like this really, I don't know, deep monetized partnership with fertility centers. Maybe I'm wrong. How do you partner with fertility centers? How do you work with them?
So great question. Yeah, and I think, look, you're right. The challenge for fertility centers in a lot of cases is how to be as efficient as possible at delivering the care that they deliver to as many patients as possible. When you have somebody come in who doesn't meet one of your, sort of basic requirements around care, that's a challenge to sort of work with that person, especially over a period of time, if they continue to not sort of be within that BMI limit that's required. What we do in partnering with fertility centers is we try to work as closely as possible with them in support of the patient's goal of fertility. That means that we try to make the burden in terms of getting patients to us as light as possible for those referring fertility clinics. And then we try to make sure that when that patient is ready to come back, we make that process of coming back to the fertility center as easy as possible. And so I would broadly kind of group our partnership into two kinds of patients. The first one is patients whose BMI precludes them from one kind of treatment or another. So we'll hear frequently that a center has a BMI cutoff of 35 or 40 or so around IVF as a broad category. And the reasons for that have a lot to do with risks from sedation and risks of airway collapse at certain higher BMIs. And the threshold depends a lot on the facilities that are available and just the policies that practitioners have put in place. For those patients who have a BMI that precludes them from receiving care, we partner with the facility to take that patient, understand their fertility goals, understand the fertility path forward for them, understand the weight target that they need to achieve in order to receive fertility treatment. Work with that patient over the course of weeks and months, independent from the fertility practice. And about the only thing that happens during that process is we update the fertility center on a regular basis, and that frequency depends really on the fertility center's preference for those updates. Usually it's about once a month. We give them an update on sort of the patients that we're working with for them. And then when that patient hits that BMI threshold, we then, with the right amount of notice, because in many cases, it takes 4 to 6 weeks to get an appointment with a treating provider, we'll say to those patients who are ready, hey, you hit your threshold, or you're about to hit that threshold, you're ready to go back. Let's get you set up with that care. We'll work with the referring fertility practice to make sure that person who previously was just not eligible for care, who previously could not have received treatment, now gets back into their practice in a pretty seamless way. And is able to get care. Typically, we continue to work with those patients because now they're in the second category of care, which is patients who are eligible for fertility services, but who who are already sort of receiving those, but who would like to continue to lose weight. And for those folks, typically we are treating alongside the referring provider. And again, we make that pretty seamless to the referring provider. There's no change.
The referring provider in this case being the REI?
That's correct. Right. Is the fertility specialist. It's pretty seamless to the fertility specialist. They don't have to do anything to change their path of treatment because this patient is actively losing weight. We always are making sure that we're up to date on the path of treatment forward for that patient and that we're practicing in line with those care needs. And the patient often, continues to lose a meaningful amount of weight as they go through treatment. We will stick with those patients oftentimes through pregnancy, and then afterwards continue to help them to lose weight when it's appropriate to lose weight again, which of course it's not appropriate during pregnancy.
So while we're on the topic of referring providers, when we say referring providers, we're typically talking about OBGYNs, sometimes right. PCPs. And one thing that I've heard from REIs for as long as I've been in the field is there's often a trepidation of disrupting their referral patterns. They don't want OBGYNs to perceive that they're taking their patients, why they always send them back. So that they'll keep getting referrals. There's probably some threads of this concern that are valid. Often, I think it's probably not valid. OBGYNs are just as busy, if not busier, than REIs, and so are PCPs. And very often we're talking about low margin insurance patients, which is why I'm interested in exploring this telehealth idea. But I can hear a couple REIs in the back of my head saying, well, why would we refer these patients out to a platform like this and piss off when we could be sending them back to their PCP to have this treated?
That's a great question. Look, I think, for some patients, the PCP is a perfectly appropriate place to treat their obesity. And in many cases, the PCP has already been a part of the discussion, right? So most patients that have obesity are counseled by their PCP that they should be losing weight. They'll ask that PCP, hey, what should I do? And that PCP will have sort of, taken them through their frontline treatment. I think the reality is, in the vast majority of cases, that mode of treatment doesn't work. And so just like we work with PCPs and, different side of our business, we work with PCPs as the referring provider, as opposed to fertility as the referring provider. And we do that because the PCPs say, all right, I understand that there is this new area of medicine called obesity medicine. And that's our subspecialty. That's a specialty in which Form Health practices. Our physicians are obesity medicine boarded. They typically come from an endocrinology or primary care background, but they've all passed their ABOM, American Board of Obesity Medicine boards. And they just have just like a cardiologist has advanced experience within their area of specialty. Our physicians have advanced experience for these harder cases in the field of obesity. So while an REI might say, gee, why wouldn't I just send this back to the PCP, who, by the way, sent me the patient in the first place? I think the short answer is, oftentimes those PCPs have already done the work that they're able to do and haven't gotten effective results. And in many cases, when it comes to actively treating these patients for obesity, many PCPs don't feel that they're sort of the right set of folks to deliver that care, which is why we work with them as referrers as well.
What evidence supports your idea that the treatment is very often unsuccessful, that obesity treatment is very often unsuccessful with a primary care provider?
So I think the biggest piece of evidence would simply be the continued upward climb of the rates of obesity in the United States, even though everybody's PCP who has a BMI over 30 will sit them down and say, hey, you really need to change this.
What are we talking numbers wise? And I know that you probably have this like memorized for VCs. So like numbers wise, what are we talking about obesity and the increase that you're discussing?
Yeah, well, look, I mean, today the obesity rate for adults in the U.S. is close to 45%, and it depends on what statistic you want to look at. There's a few that are now suggesting that with the pandemic and with folks being home, there's been some pretty substantial increases in that number. But here in as recently as 1980, the rates in the U.S. were 10%. Right. This is a health challenge that up until January of 2020, along with opioids, was one of the two major health problems that the U.S. faced, and I think we haven't seen sort of any change there. That is despite a lot of healthcare focus in the area and a lot of counseling from PCPs. I think the challenge is that for many doctors, that there's a sense of, hey, to deliver the right care for obesity medicine, to deliver the right kind of care around weight loss, we need to have a pretty active set of interactions with the patient. So Form Health, for example, meets with our patients once a month with their physician, twice a month with a dietitian. So they're seeing somebody from Form Health almost every week. And then we're a fully virtual program, so everything happens through an app. So then those patients are talking with us almost every day. On average, we talk to our patients every day. And that's just not a sustainable model for a traditional primary care practice. In addition to that, for some patients, and there is an asterisk here because for patients who are or may be pregnant or working to get pregnant, many of the medications in the space aren't always appropriate. But for many physicians, there's a world of medications that are helpful to patients, and they're not comfortable in prescribing those for a variety of reasons that have to do with training and history and all this sort of stuff. And so that's why a lot of physicians today are excited to refer out to specialty focused obesity medicine programs.
What kind of results are you seeing now? And if you're still in forecast mode, how will you be measuring the results?
Yeah, it's a great question. So we've seen results that are best in class for obesity clinics. We have our specialty, as I mentioned, is obesity medicine, and so there's a fair amount of research that looks at the rate at which folks are able to lose weight. For us, patients that are doing great can lose up to 25% of their body weight over the course of 6 months. Those are the results that we have seen. So very, very substantial weight loss. Typically, a patient is losing, about a pound a week. And, for some patients, they'll stop and they'll say, hold on, a pound a week, shouldn't I be able to lose it faster with a medically engaged program? And the answer is no. If you're losing weight much faster than that, then it's not sustainable weight loss. And you're much more likely to stop, and you're much more likely to see rebound after that. And so lots of studies today show that, about a pound a week is sort of the upper threshold for how fast somebody can lose weight. It's a little faster than that when you start weight loss, but the sustained rate is about a pound a week. And we see that. And I think the thing that's really important for our field is how long does somebody stay in this kind of program. So for a lot of more traditional weight loss, either self-guided or guided through a program like Weight Watchers, et cetera, people retain on those programs for a very short period of time, right? We're talking 20 days, right? 22, 23 days is sort of average retention there. And if anybody's tried it themselves, you've probably had a similar experience. The first 2 weeks, you were really motivated. The third week, you started to say, I don't know if I want to keep doing this. And by the end of the third week, you had a couple of reasons not to, and you didn't. What we see is that about 75% of our patients are still with us at 6, 7, 8 months. That's a lot, right? And when somebody sticks around with you for that period of time, you're really able to help them make material changes in their lifestyle, and health, and you're really able to see those folks go from a very high BMI down to something that's more more clinically helpful.
Have you done any abstracts yet?
We've done a couple of posters. We did a poster at the Obesity Society here last year, and we did one at ASMBS, the American Society of Bariatric Surgeons, here this year.
Summarize a couple of those findings for us.
Yeah, I think in line with what we just talked through. So typically patients are losing about a pound a week, and that we see that retention that is very substantial during the forecast period. I think the results that we're the most proud of are actually coming out of some of our work with fertility centers, where we had just this month 2 patients who became pregnant, who had been having real challenges or weren't eligible to be getting fertility services because of their weight. And after working with Form, went back to their REIs and are now working on building a family. So that's the kind of thing that we get really charged up about.
And that's what the audience gets charged up about too. A pound a week and a longer enrollment in the program for the intervention. What compared to what baseline? I guess what is the average intervention yield?
Well, that's really important. The average intervention, self-guided intervention, doesn't yield anything. And so I think that's the really important thing to think about. So, the alternative to referring to an obesity medicine provider is to tell a patient, hey, you should maybe join a Weight Watchers, or you should work on this yourself. Self-guided interventions, because they don't last long, don't tend to show great results. Weight Watchers and others have some good clinical studies where they will show that their population is able to lose weight, but the lived reality of somebody on Weight Watchers is very different from a lot of those studies. And the reality is most patients don't stick around on those studies for very long. And so I would suggest to folks that are listening to think about their patient population and think about those people who they've said, hey, if you want to have better outcome, I need you to lose some weight. And think about sort of what percentage of those folks were actually able to achieve that weight loss. In our experience, and sort of more broadly, looking at the broader population data, it's very unusual for someone to be able to, under sort of self-guidance or under a more purely behavioral program, to lose a significant amount of weight. We're not talking about 10 pounds, but lose 30 plus pounds, and to keep that off. That's very rare.
Yeah, well, I was going to ask, how do you stratify that a little bit more? Because I imagine some people would say, well, these programs work excellently. And so to say like self-intervention doesn't work, it could be right. But what are some of the parameters that that show us that that's true?
Yeah, well, so I think one of the biggest one is just sort of the overall gain in BMI across population, and again, that's been the rate of obesity has been ticking up very substantially over the course of the last decades with really no pause. Right, there is not a year in the last 20 where the obesity rate in the country in the U.S. has gone down, and that's generally the case globally. And so I think that again, if a person is not able to stay on a plan for more than a handful of weeks, they will not be able to achieve results. You can think about weight gain typically takes a while. So for many patients, they're gaining a couple of pounds a year on average, and they may have a year or two and they gained a substantial amount of weight. But if you ask them kind of what was the trajectory of your weight gain over time, typically it's a couple of pounds a year. And just like weight gain can take a while, that weight loss often can take a while, even when it's medically assisted, right? The fastest that you can go is about a pound a week. And so for a lot of patients, what they find is, gosh, if you're staying on that program for 14 days or 20 days, that might be fine if you want to lose 5 pounds to go to the beach or for an event or something like that. But when you're talking about sustained weight loss, most patients, the vast majority of patients, benefit from that intervention.
So how do how does Form Health get paid? Is there a partnership from the fertility? Is that a paid fee?
It's a great question, and the answer is no. So there's no cost to the referring provider, and we look at this partnership as working to help we're going to help these individuals, our mutual patients, to achieve their broader health goals. In the context of fertility, the number one goal at the top of the list is I want to have a baby. And that's the goal that we are working towards together. But just like the fertility specialist, just like the REI is not paying and is not able to pay because of Stark laws, their referring provider, there's no fee to the provider who refers patients to Form. And we think of this in terms of what value can we provide to that provider. So that's why we are keeping them updated in an effective and pretty efficient way for their time in terms of how these patients are working. That's why we're making sure that we're treating in line with that provider's sort of needs for that patient when we work with them. And really, at the end of the day, this is just about us helping these patients together to achieve that fertility goal.
So is it a monthly subscription from the...
Great question. Yeah. How do we get paid broadly?
Mm-hmm.
So there's two parts to how our economics work. We are a reimbursed service. So when a patient sees their physician, that service is submitted to their insurance, just like any other physician interaction would be, and then that's sort of adjudicated through their insurance coverage, et cetera. Any cost to the patient for labs, any cost to the patient for medication, all of that sort of runs through their insurance, just like it would for any other medical interaction. And then in addition to that, we have a monthly fee that's $99, and that really covers the cost of the dietitians that the patient works with. So there's two parts to that team. One is the physician, two is the dietitian. And so those dietetic services are covered by the $99 a month fee, which is paid for by the patient.
I want to talk a little bit about the insurance and telemedicine, and that will make this tangent make sense, because in February 2020, I was at a small fertility conference, very cool, intimate fertility conference in Colorado. And we were starting to talk about this novel virus that was developing in the East, but
haven't heard of it.
People didn't really know what was going to happen yet. So this is like the first week of February. And at that conference separately, we were also talking about the future of telemedicine, but also kind of how it was a pain in the neck, because, if you practiced it, if you hadn't, let's say you're in Erie, Pennsylvania, and you're seeing patients just across the border in New York State, that you would have to have in some states, I don't know if this is true for Pennsylvania and New York, but at least in some states, you'd have to have a license to practice in both states. And
that's the case in the majority of states.
Okay. And then all of a sudden, a month later, a lot of these regulations were put on hold. Health and Human Services and Office of Civil Rights, I believe, are the two agencies that enforce HIPAA. And so they said, you can use Zoom, you can use FaceTime, you can use Skype. And so how did that affect or not affect you all at that time?
Really, really good question. We have been a purely telemedical business since we got started, and so we have been working within the sort of fairly complicated telemedical regulatory regime that exists. And so for us, in some ways, we were already really prepared for everybody to get pretty excited about telemed. We didn't change the way that we work with patients. We already had tools that were HIPAA compliant that were in place. I think some of the benefit to some providers was that some of the interstate licensing requirements were waived or otherwise loosened for a period of time. I think for us that didn't have a big impact either, because our providers were already sort of licensed in these states where they practice. And for us as a growing business, our perspective was we never know how long these waivers are going to last, and they are really important for some of the emergency or near emergency medical treatment that had to happen around COVID. But we didn't want to build our business on some of those sands that could shift pretty quickly. And so by and large, everything that we did was highly compliant with the pre-waiver world of telemedicine.
No, that your explanation of how you get paid from patients and from insurance companies and not from centers is part of the reason why I had you on the show. If people sell to centers, then they're going to be more likely in that sponsorship category. I know that some other people are still going to say to me, "Oh, that's me too. Why can't I come on the show?" Listen, sometimes I'm in a good mood. Keep trying me. And but I am really interested in the idea that we have to be getting people to other solutions that are found in tech. And and I do think that we need to be propagating that for the triage aspect. One concern that I've seen is we've seen people come in, and there's been a couple of them that thought, oh yeah, they're going to be great, they're going to stick around, and then it's like, whoop, they burnt through that money pretty quickly. I didn't know you could burn through $60 million that quickly, but apparently you can. And VC is
great parties. That's the
world. So what challenges are you on the lookout for?
Yeah, look, I think we think that, not surprisingly, the world of obesity medicine, the specialty of treating folks with BMI north of 30, or in some cases BMI north of 27 with certain comorbidities, we think that is a big growth area in healthcare broadly. Today, only about 1% of individuals with a BMI north of 30 are receiving medical treatment for their weight. If you look at any other major medical condition, from type 2 diabetes to high blood pressure to depression, typically treatment rates settle out for reimbursed services at about 2/3. And I think we are entering a world with AMA recognizing here about 7 years ago that obesity was a medical condition with the creation of the American Board of Obesity Medicine. We are entering a world where treatment of obesity will be more the norm than it is the exception. Today, it's absolutely the exception, and I think that that's part of why fertility, for example, has been a big growth area for us, because patients' weight so directly impacts their ability to conceive and to carry a child to term. And so I think we are headed over the next 10 years towards a world where treatment is more the norm, where we start to see treatment rates north of 50% for individuals with a BMI north of 30. And that doesn't mean that all those people will go to obesity specialists, right? Primary care will start to treat this more frequently, et cetera, et cetera. But, in that world, what we are really looking at over the next 10 years is an incredible period of growth. And I think, for us, as a result, some of the biggest areas of concern are really just, how do we grow effectively? How do we support that growth in a way that matches with our very high level of standards for the care that our patients receive? And how do we continue to do that as we scale larger and larger and across more and more states? So I think, the question for folks in our space is, as awareness grows, as referrals grow, as practitioners start to say, well, I'd refer out, if I saw high sugars, I'd refer out for treatment for what looks like it might be, a case of diabetes. If I saw high blood pressure, I'd probably refer out for that for treatment as well. I'm seeing somebody coming with a BMI of 30. That is a medical condition. Of course, I'm going to refer out for that. Right? And as that becomes more of the norm of thinking, I think the real questions are, how do we as a specialty of medicine, how do we make sure that we support that growth in a way that's going to be effective and high quality for all of our patients?
So what do some of the obstacles look like? Like you as the visionary of this burgeoning company, when you are thinking that 6 months to a year, what are the things that you're saying, this is what we're getting over as a company in the next half a year or so?
Yeah, well, look, I think, supporting demand is always a big challenge as a growing company, right? So what we have seen in working with fertility providers and other physicians more broadly is the impact we've been able to have really has been positive for their patients, and as a result, we'll often start with as an example, with a fertility provider. And they'll say, great, I'm going to refer you the folks that come in and their BMI is over 45 because I can't do anything with them unless we bring that BMI down. And within a couple of months, we're seeing everybody with a BMI north of 30. And they're actively treating those patients between 30 and 45, but they've seen such great results with the patients that have a very high BMI that they start to say to everybody else along the path, hey, let me just toss these folks over to Form, because they know the support is there, they know the results are going to be there, and this is something that the patients want to achieve along with their fertility. And so I think, for us, we look to growth, and we look to making sure that we continue to support those patients in the best darn way that we possibly can. I think the world of COVID is an interesting challenge for us as well. We are, as I mentioned, purely telemedical. Patients never come into an office. That's really comfortable for patients because now they don't have to leave their home, and even as they go back to work, they don't have to leave the office. They can sit, in a conference room like I am now, and have that conversation with their practitioner, receive treatment, and then go on about their day. But I think that we're going to see what changes in people's expectations. What we've seen across our business is a lot of folks have had some pretty material unplanned weight gain during COVID, and so I think that is both an opportunity and a challenge because there's more folks that need help, but at the same time there's a lot more obstacles in their way that are causing them to gain weight too. So I think there's some challenges from the medical side, there's some challenges from the business side.
I thought of two more questions that the audience will be grumpy with me if I let you off the hook about. Then I've got a selfish question for myself that is of zero value to the audience. And then lastly, you can conclude with however you want. So, but I know that some people there is sometimes a referral paranoia in this. And again, I think most of it is unwarranted most of the time because of how busy we all are. But some people may see you've had luck at least building the beginnings of relationships with a couple groups. They see another group on there, like, well, that person is 2 miles away from me. If I refer patients to Form Health, they're going to refer them back to this other group.
That's interesting. So I think all of these are things that we work really hard to just make sure aren't an issue for our referring physicians. When we receive a referral from a physician, we mark that down, and we are working with that physician at the very least, keeping them updated on their patient's progress. And then sometimes if that patient's actively receiving treatment, then we'll kind of get the note from the referring provider to make sure that our treatment path is still in line with their path of care for that same patient. And when it comes time to send that person back, we are already queued up with that referring physician, the one that sent us the patient in the first place, and we just sort of naturally send them right back. And we keep pretty good records on that internally, mostly so that we can stay in line with that physician's path of treatment. But this isn't something where somebody sends us a patient and we say, okay, well, who do we like in the city of Boston? Let's just send them to to that referring provider. I do think, we do have growing relationships with a number of providers nationwide, and we have been excited to support our relationship with those providers. So we have a bunch of providers that say, great, we help generate some content with me. We're always happy to lend our medical experts out to build a little bit of content with them. We've got mutual web pages that we stand up. There's the opportunity to do some joint work in building sort of practice volume, and we're always supportive of that. I think we want to do whatever we can to help differentiate our practice partners, our referring partners, and help make it clear to patients that in coming to this specific REI, it's not just, hey, you're here for one thing and one thing only, but it's a holistic solution that can include weight loss, that can include all the things that patient needs to make sure that they can have the best chance possible of fertility.
Hopefully that's a more superficial concern. The more sincere concern that they will not let me off for letting you off is, what are you doing with the data and what are you going to do with the data?
Good question. What we do with the data now is make sure that we're treating our patients appropriately and effectively. I don't think that we have any plans around looking at referral patterns or selling that data to other sort of like larger data entities or anything like that. I think there are opportunities. The things that we are really interested in doing with that data is publishing and making sure that the ways in which we are working with patients and the centers that we are working with, are really able to show the difference between those patients that they worked with and help bring the BMI down and some of the success rates they had there, versus those patients who, for whatever reason, weren't appropriate to refer or weren't interested. And so we are actively working on a couple of paths now to start to publish with some of these larger fertility groups. And if any of your viewers out there want to be part of something like that, where we can really take a look at the impact of weight management around fertility treatment, that's something where we're looking to add additional practitioners and groups into some of that work that we're doing.
Okay, I think I've poked you to the extent that most of them would poke you. I think most satisfaction has been filled. This is totally just for me. My two favorite influencer docs outside of the fertility field, everybody, this is outside of the fertility field. My two favorite influencer docs outside the field are Jason Fung and Peter Attia, and for their research and work on longevity and specifically with fasting protocols. So this is just me. This is just me really curious how much of your protocols involve fasting, or is that in your purview at all?
So not really. And I guess the first thing that I'd put next to that is, I think Fung and Attia are often working with folks that have very different health challenges than those people who are dealing with obesity, right? To the extent that I've read some of their stuff, and I think they're pretty interesting, but they're really working on folks that are, kind of already, pretty far down the road of hitting all of the basics of healthfulness, and are trying to kind of tweak and do a little bit of biohacking and really make sure that they're squeezing the most they can out of their lives and their physical bodies. And I think that's pretty interesting. We certainly do work with patients on multiple different protocols that help them to control calorie intake. And so, there's two big pieces of our care. One is working with that physician. Two is working with the dietitian. Intermittent fasting is absolutely one of the tools that our dietitians use. Not so much for, some of the outcomes that Attia and Fung might be, really focused on, but just because there's a lot of data around IF that suggests that for some people, it's really helpful with controlling caloric intake. I think we're a little bit more skeptical on data suggesting that your body is burning more calories when you're doing intermittent fasting, or that you have sort of increased metabolic activity when you're on IF. But we absolutely see that it's super effective for a lot of people in helping them to control appetite, which helps them to control calorie intake. So given that, the reason I said that it's not really part of our program is it's not a required part of the program. What we do is we try to work pretty carefully with each patient to make sure that the dietetic approach we take with them is built for them. And for some people, IF just isn't effective. For other folks, they want to try a different kind of restriction. They might want to try, meal replacement, or we may believe that's going to be highest impact for them. And so we work within those protocols. But there are a number of our patients that do IF, and many of them find it to be pretty impactful. But they apply it, and it is applied a little bit differently than what Atia and Fung are typically thinking of.
What we got to do is get you a show so that you can have those guys on your show.
That'd be fun.
And then they can see if they see it the same way. But that's just for me. This audience is mostly REIs, mostly execs in the fertility field, a lot of practice owners. So how would you like to conclude to that audience, Evan?
Yeah, I think, first, it's been fun to have the opportunity just to chat with you. I think to those folks that are listening, Form is a practice that is really built to support your patient's outcomes. And we work today with dozens of practices across the country to help their patients to achieve better fertility outcomes, to achieve more pregnancies and carry more pregnancies to term. And we strive to do that in a way that has as little friction to their practice as possible, but helps them to work with more patients and deliver better outcomes. And so I think, to the extent that is something that folks are excited about, and at least in our experience, a lot of practitioners are excited about working with more patients and improving outcomes for all their patients. We're ready, and we'd love to hear from you. And you can track us down at formhealth.co.
I think this is the trajectory that we need to, at the very least, look a lot more into in the field to help expand tech's use of applying the rest of the health treatment that we might not do. And thank you very much for coming on Inside Reproductive Health.
Thank you. It's been a lot of fun.